Good afternoon, everybody. Before we begin, I would like to let everybody know that this session is being recorded. These recordings will become available on our website after session. We are very excited to have all of you join us for the 16th Dent Echo. My name is Kato, and I will be assisting in facilitating today's session. For those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions include a didactic presentation and de-identified case-based learning and group discussion to foster deep knowledge and build individual capacity. Some notes before we get started. Please stay muted unless you're speaking. You can also use the chat to raise questions and share your perspectives. Please remember that no personal health information is allowed in either the chat or our discussions. To help with attendance, please enter your name, affiliation, and email into the chat. If you would like assistance with your connection throughout the session, please chat our lovely Dent Echo IT, Karen. These sessions are enabled for closed captioning. If you would like to view captions for this session, please navigate to the bottom of your Zoom window and select the Show Captions option in the More menu. And to receive CDE credits, registration is required through the UT Health CDE website, and you would need to be on the session throughout the duration of the presentation. We will also follow up by email with instructions for completing the post-session evaluation and attaining your credits post-session. If you haven't already completed the pre-session questionnaire, you can do this now using the link Karen dropped in the chat. Also, we are always looking to recruit more case presenters. If you have a case you would like to share with the Dent Echo Network, please let us know. ECHO is an all-teach, all-learn supported model, and ECHOs thrive on the interaction from the full learning network. So we encourage all to participate in the conversation today. We also encourage you to join by video if you can, especially during discussion portion of the session. Our session today will include a didactic presentation from Dr. Daida on pediatric dental care in uninsured patients, exploring our alternative treatment options, and case presentation from Dr. Contreras. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and perspectives. And with that, we'll move on to introductions. Dr. Challa.
Welcome, everyone. I'm Suman Challa of Saving for Advanced Education Programs and the principal investigator for this grant that supports the day.
Thank you. And Dr. Marwaha?
Hi, I'm Dr. Marwaha, and I am a clinical assistant professor at the Department of Comprehensive Dentistry and a part of the Hub team. Welcome, everyone.
Dr. Dar.
Hi, I'm Shohini Dhar, clinical assistant professor with Department of Comprehensive Dentistry and also part of the Hub team. Thank you.
And Kathleen.
Good afternoon and welcome. My name is Kathleen Weeks, and I'm happy to be part of the Dent Echo Hub team. I'm currently the project coordinator here at the School of Dentistry. Thank you.
And is Dr. Rankar on? All right, Dr. Daida.
Hi, I'm Dr. Daida. I'm a clinical assistant professor here at the Department of Developmental Dentistry.
And Dr. Contreras.
Hello, everyone. We're just sharing a computer because we're off campus, but I'm glad we're able to do this. Welcome, Claudia Contreras, and I've been with the school for about 18 years. So hopefully these cases they're really interesting, but the information, you got to have that information. So welcome everyone for today.
Thank you. And Dr. Daida and Dr. Contreras, whenever you're ready, please share your slides and please take it away.
Right here.
Mm-hmm.
Is that true again?
Yeah.
Okay.
All right. Is everyone seeing?
We're seeing that. Yes.
Oops. Just a sec here. All right.
Can you see the presenter view?
Yes,
Yes.
it looks great.
All right, great.
So I'm seeing this.
Are you seeing the notes as well, or just the slides?
Just the
Just
slides.
Okay, perfect. Thanks. Good afternoon. Our presentation today is Pediatric Dental Care in Uninsured Patients, Exploring Alternative Treatment Options. My name is Stan. I will be presenting the didactic portion of this presentation. Dr. Contreras has a couple case presentation afterwards, and we are both pediatric dentists here at UT Health San Antonio. We have no conflicts of interest. The main objective of today's presentation is, what can we do if we can't do traditional dentistry right away? Well, we assess our patient and develop a plan to keep the caries from getting worse. So today, we're going to learn about caries risk assessment and become familiar with AAPD guidelines and minimum interventions that we can do to slow things down. We are going to focus on patients in primary or early mixed dentition today, and we'll have time at the end of my presentation for questions as well as Dr. Contreras's. Kids with no dental treatment don't have, kids with no dental insurance don't have much dental treatment performed unless something urgent like an extraction needs to be done. The common scenario would be a patient comes in for their first dental exam and they have a few teeth that need to be treated, but we can't do anything right away until parents have money to pay for it or acquire dental insurance to pay for it. So ideally, we want to see the patients before problems occur, and we want to work with the patients towards good oral hygiene and healthy eating habits at home. And we want to have different options available to slow caries down. First things first, we need to know our patient. Before we look in the mouth, we want to talk with a parent or caregiver and see what is currently going on at home. How is the brushing? How often are they brushing? Are they brushing twice per day with a fluoridated toothpaste? What does the child eat and drink throughout the day? Does it take a long time to finish meals? Do they snack throughout the day? Does the child have special health care needs? Any dietary restrictions or difficulty in maintaining good oral hygiene? Are there any medications causing xerostomia? Have the parents had a lot of dental treatment in the past? Do they currently have teeth that need treatment? What about the siblings' oral health? What are the parents' thoughts and perspectives on dental health? Next, let's take a look in the mouth and see what's going on. Is there a lot of plaque, dry mouth, tooth defects like hypoplastic teeth? Are there any caries? How many?
The Contreras. Seems like it froze. Let me see. Can you hear us? Evelyn, would you be able to connect with Dr. Contreras? It seems like their internet might have gone out. We apologize, it's a technical issue. Kathleen, are you able to connect them? Okay, I see that they're trying to connect back. Dr. Daida, can you hear us? Can we hear you?
Okay.
Would you be able to share screen and continue?
We're going.
We're getting there. This one?
Perfect. Thank you.
And now do the. um, Very good.
Are we back?
Yes. It looks great.
All right. So this is the risk assessment form we use here in our department for patients less than 3. Risk factors are divided into low, medium, and high. As you go from low to high, caries activity increases while preventive factors like oral hygiene and fluoridation decrease. Please note on the form that sugar consumption at mealtimes only is a risk factor we'll talk about later on. Here's our form for patients aged 3 to 5. Low risk factors remain unchanged. Special needs patient has moved to moderate risk. Inactive white spot lesions are a moderate risk factor, while active white spot lesions are a high risk factor. And finally, this is our form for patients aged 6 to 20. Special conditions risk factors that occur in this age group are present, such as dental, orthodontic appliances, drug, alcohol abuse, and eating disorders. In addition, the previous dental treatment section between moderate and high has changed. 1 or 2 restorations within the last 36 months is a moderate risk factor, while 3 or more restorations or an extracted tooth within the last 36 months would be a high risk factor. So we take all the information and fill out the appropriate caries risk assessment form to assess their risk. Now that that has been done, a plan for caries management can be developed. Many variables come into play when managing caries. Since this presentation is focusing on patients with no dental insurance, we will be focusing on ways to prevent and slow caries progression. The plan will have 3 parts. We have already discussed the part 1, which is assessing caries risk. In a minute, we'll talk about developing a prevention plan, which goes over dietary recommendations, oral hygiene, and fluoride varnish. To make sure what we're doing is working, we want the patient to come back often to be assessed. A 3-month recall would be a good place to start. Finally, we want to have options to slow existing caries down. Options include fluoride varnish, silver diamine fluoride, interim therapeutic restorations, and Hall crowns. Ideally, a child's first visit should be within 6 months of their first tooth or by their first birthday. We want to identify problems before they occur so a low caries risk can be established and maintained. This is where we want to end up with our prevention plan. Clean teeth, good fluoride exposure, sugar consumption at mealtimes only, and an established dental home. Here are some of the main dietary recommendations. Breastfeeding should discontinue around 12 months of age, and on-demand as well as nocturnal feeding should be avoided. Plain fluoridated water should be introduced around 6 months of age. No fruit juice before age 1, and added sugars should be avoided in children less than 2 years of age. There's a lot more recommendations as well. Bottom line, food habits are hard to change in anyone, myself included. Which brings me to this slide. Goals need to be realistic. I once told my physician that I struggle with ice cream. Sometimes I would pick up a pint on my way home from work and eat the whole pint after dinner. Their recommendation for me was to try eating a serving size, which would be around a quart cup, and put the rest in the freezer. Realistically, in my mind, the serving size is the entire pint because it conveniently fits in my hand. As a result, I did not make a change. It was neither realistic or attainable to me. So we always need to keep in mind what we're asking our parents and patients to do. On our department's Caries risk assessment forms, sugar consumption at mealtimes only is a low risk factor. So recommending that goal, as well as healthy snack options, is a reasonable goal to work towards. And that was what I was doing. I had a low Caries risk factor behavior with that, so that was good, but not for diabetes, obesity. All right. Oral hygiene. Parents should brush twice per day for about 2 minutes each time. Parents or caregivers should help with toothbrushing until the child has good manual dexterity, which would be drawing a circle or tying their shoes. A lot of parents don't know when they can start using a fluoridated toothpaste. Quantity is key. A smear for children less than 3 and a pea-sized amount for children aged 3 to 6. So here on the left, we have about a pea-sized amount. And on the right, we have a smear-sized amount. So basically, just enough to just coat the tips of the bristles of the toothbrush. Then fluoride varnish. Fluoride varnish is the recommended fluoride treatment for our younger patients. If the caries are cavitated, other options need to be considered. And they are silver diamine fluoride, interim therapeutic restorations, and Hall crowns. 38% silver diamine fluoride is the concentration that is commercially available in the US. The exact mechanism is unknown. It is thought that fluoride works on the teeth, while the silver has antimicrobial properties. It has been used for many years outside of the US. The major drawback to silver diamine fluoride is that it discolors demineralized and cavitated tooth structures black. This is a major aesthetic problem for parents, especially for visible areas like the facial surfaces of the maxillary anterior teeth. Silver diamine fluoride is better at arresting caries than fluoride varnish, and more fluoride is retained compared to other fluoride treatments. Also, you can place resin or glass ionomer materials on top of caries treated with silver diamine fluoride, and it will not affect adhesion. Silver diamine fluoride works best on maxillary anterior teeth and buccal and lingual smooth surfaces. As long as the tooth has no clinical signs of pulpal involvement and the patient is not allergic to silver compounds, silver diamine fluoride is a good option to try and arrest caries. The biggest hurdle is parents being okay with the color change that occurs when it is being applied. That being said, informed consent with illustrations showing before and after silver diamine fluoride is applied is highly recommended. In addition, parents need to be aware that it will permanently stain clothing and temporarily stain skin. Also, silver diamine fluoride may need to be reapplied in the future. After informed consent has been applied, we want to prepare the patient for applying silver diamine fluoride. Use universal precautions. Protect patient's clothing and eyes with a bib and glasses. Isolate the teeth appropriately with cotton rolls or an isolite. Place SDF in a plastic dappen dish. Have a plastic bag available to use when you are done applying SDF. Caries does not need to be removed prior to application. Dry the caries. Dip the microbrush in the silver diamine fluoride. Dab against the dappen dish to remove excess and apply to caries for 1 minute. After application, gently dry with air water syringe for 1 minute. Remove excess SDF with gauze or a cotton roll. Try to keep the area isolated for up to 3 minutes. And these times may not be attainable with all patients due to age and behavior. Afterwards, patients can eat and drink, and they can brush that evening. Patients may tell their parents that they have a metallic or bitter taste. If the SDF stains soft tissue, it should go away in 2 to 14 days. Finally, parents need to be aware that silver diamine fluoride may need to be reapplied at a later time as well. Interim therapeutic restorations are another option that we have available to slow the progression of caries when traditional dental treatment cannot be done. The goal of an ITR is to achieve caries-free cavosurface margins and then restore with glass ionomer or a resin-modified glass ionomer restoration to seal the remaining caries underneath the restoration. You don't need to use local anesthesia. So this could be a good option for children who have caries on the facial surfaces of the maxillary anterior teeth if parents refuse silver diamine fluoride. To place an ITR, remove caries with rotary or hand instruments. Do not expose the pulp. The goal is to have clean cavosurface margins. Once that has been done, restore with glass ionomer or a resin-modified glass ionomer material. ITRs work best on single surface or small two-surface lesions. The last option discussed today will be the Hall crown. Similar to the ITR, the goal is to seal the caries underneath the restoration. But this time use a stainless steel crown without tooth preparation, caries removal, or a local anesthetic. Indications for a Hall crown. Essentially, a primary molar with caries that is not pulpily involved can be restored, and the patient cannot tolerate traditional dental treatment. Contraindications to a Hall crown: teeth that are pulpily involved, non-restorable, and children who cannot cooperate with the procedure. To do the Hall technique, place ortho separators if needed and have the patient return 5 days later. Remove the separator and select a stainless steel crown that has spring back, meaning it should have some resistance at the height of contour, but will seat. Evaluate the fit. If there's any impingement of the gingiva, remove the crown and trim as needed. After adjustments, fill the crown with glass ionomer cement. Seat the crown and have the patient bite down. Remove excess cement. After the cement has completely set, remove the residual cement and floss the interproximal contacts. After the procedure, we need to review post-op instructions with the parents. They need to be informed that their child may say that the crown is high or hard when they bite down. That is normal, and the occlusion will equilibrate over time. Also, the child should avoid sticky foods that could pull the crown off. So we'll pause a moment here to answer any questions that you have, and then Dr. Contreras will review a couple cases where minimum interventions were done. Okay, stop sharing.
Thank you so much, Dr. Daida. Does anyone have questions for Dr. Daida regarding the didactics or just any general questions for Dr. Daida?
I have a question. So I saw that in the slide, he noted that glass ionomer and composite can be placed over a SDF restoration. Is there a period of time between? I know all of these interventions we're pretty much trying to avoid or delaying treatment or some permanent restoration, but is there a specific time frame as to which you have to wait between placing the permanent restoration?
Do you mean, and this is Dr. Contreras.
Put it on there and restore the same day?
No. I'm just asking, like, I understand that the goal of this is to delay treatment, but what is the time frame between when you apply the SDF the first time and then place in the permanent restoration? Like, how long do you have to wait, if that makes sense?
I think it all depends on the behavior.
Yeah.
It really does. If you can, are ready to apply it that day, fine. If mom was having a hard time with the behavior and just seeing their child maybe struggle with the procedure, you want to delay it maybe a week, but we're not going to try to delay it 3 months, right? So also if it's cavitated, we have some lesions that are cavitated, which food gets stuck. So even with the application of the SVF, which is, we've seen it to be very effective, it's when the food starts to get impacted and they can't clean it. Then that starts to basically starting to be as not effective since food is starting to get in there. It's like the bacteria has gotten more, the food's going in there, and it's kind of wearing off the SVF. Did that answer your question?
A little bit.
Can you do it in a day?
So I think like, so more right now, more so I treat more adults. And so one of the things is that you don't put fluoride varnish on a tooth that you know that's going to be restored within the next couple of weeks. So that's why I'm asking for SDF. It makes me think you would have to wait maybe at least 2 weeks for to get better adhesion. But maybe since we're talking about primary teeth and the teeth are going to exfoliate on their own, maybe that's why it's not as detrimental or important, so to speak, if that makes sense. But that does answer my question though. I'm good though.
And I see a hand up here.
Yeah, Abdul, hi, how are you?
Hi.
Thank you for such an informative session, doctors. I have a question. Can we combine between two techniques like making SDF and then applying whole crown? Will be more protective for the primary dentition? Is it good?
I would say, yeah.
Yeah,
It all
thank you.
depends on the depth.
Yeah. Yeah, that too.
And even with interim restriction technique, I can make like a glass armor, then putting whole crown.
You'd be kind of doing the same thing because you would have the glass ionomer restoration and now you're cementing it over, you're putting the hull crown filled with glass ionomer cement over that restoration. So I think you would be okay just doing the hull crown instead of the ITR and then the hull crown.
So I'm afraid of spreading caries and the bulb may be involved later. So I'm doing this to try to not to be involved in later time in the future. Is it okay?
Can you repeat the question one more time, please?
If I put the whole crown directly on the caries, and
Yes.
so there may be like the caries may spread in the future and the bulb may be involved. So
possibly.
Yeah,
I mean, so that is possible. Ideally, when you put the crown on, you should get a really good seal, and then that will prevent the caries from growing bigger. But it's always possible. I mean, so let's say you have a tooth where the caries is really large and they're not showing any clinical signs of any pulpal involvement yet, but you do put a hull crown on. You can always inform the parent that the tooth is not showing any signs of pulpal involvement now. We put the crown on today, but it's possible that this tooth, because of the size of the caries, it may have started its decline, but it wasn't showing it yet. So although we're putting the crown on this tooth today, there is a potential chance that the tooth may become pulpally involved at a later time and potentially be extracted.
So SDF with whole crown will be the better solution.
Yeah, I think so. Yeah, if you have large caries, if the caries is too large to place an an ITR on, you would want to put a Hall crown on top.
Mhm.
If you
Okay.
try to put an ITR on a large carious lesion, there's a good chance that the tooth may fracture later on.
Yeah, I got it. Thank you, doctor. Thank you for
Yep.
your information. Thank you.
Thank you. Are there any other questions before we move forward to our case presentation for today? All right. So Dr. Contreras, if you can share the slides and if you can.
I want him to
please
be in there.
take-
Let me continue and get to the PowerPoint.
Vito, there's a comment in the chat.
Oh, thank you for letting me know that, Kathleen.
I can't.
Yes,
see that.
from Kaushik. Are you able to unmute and ask the question? Kaushik, or, yep. Oh,
I can't hear you, Dr. Kaushik.
For the 6-month-year-old dental first home babies who are edentulous, toothbrushing has not been initiated and neither can you apply fluoride. So the caries risk assessment forms show that the high risk. Would it be a high risk because of low fluoride exposure since there are no teeth in the mouth?
I wouldn't necessarily say that yet. Yeah, I would wait until the teeth are in the mouth to, take that risk factor into consideration.
So until then, should we put a moderate risk perhaps, if not high?
It could be anywhere from low to moderate. Are they breastfeeding at will? Are they not cleaning the gums even with a washcloth or something to remove the residuals? Those are habits that at 6 months, they're probably going to continue. And so once we are still continuing with the bottle, I had a case today that they're still on the bottle, age 1, they sleep with the bottle. And I happen to do interim therapeutic restorations on a 1-year-old today. But mom did not want SDF because of the black.
Okay. All right. Thank you so much.
Okay. Let me see if I'm not that tech savvy, everybody knows. Because let me see. Give me a second. And I'm going to share my screen with this one.
Yeah.
Okay. Has everybody seen? Oh, can everyone see the presentation?
yes, it looks good.
Yes.
Okay. Well, good. So good afternoon, everyone. This is something interesting, and I believe we learned a lot during the pandemic, and everyone remembers that we learned a lot, right? Aerosols and other things. But let's go on with this case. It's a 10-year-old currently, and we are still seeing this patient. And the first chief complaint was her daughter had some cavities, and we're talking about 9/17/2020. And that is where we're going to be doing the hauls. Her medical history, she's an ASA1. There's no non-drug allergies. She is not on any medications or prescribed anything. And she's been coming for first dental home visits, or actually infant exams, since the age of 13 months old. She did have a history of a pacifier, and that was seized around the age of 3. And then she comes for an operative visit, okay? And at that operative visit, this is the one we're going to do the Hall crowns, but I'm going to introduce some other things as well. So if you look at her vitals, everything's good. This is a healthy child too. And as we remember, BMI is not everything. With children, we always want to look at the percentiles, okay? And previously, she had lesions on E, F, and G on the linguals. And that was in 2016. And there we actually did SDF, okay, on those anterior teeth. And there was a reapplication in the year 2017. And tooth I also began with cavitation. So let's take a look at our first x-rays. Hopefully you are able to see that there are some lesions, and I will get my laser pointer out. There's some lesions on tooth E, F, and G, right where that dot is. Basically where I'm putting the laser pointer, that's where the caries are. And on tooth I, even though you cannot see this, it had an occlusal in that area. So these are our first ones. And then this patient comes back and she has a history of having an oral sedation to complete the treatment. What was completed? This was done in August of 2017. So this is basically a year later. That's why you see the restorations. So they did some restorations on E, F, and G. Also tooth I, it has a restoration, as you can see in that area. Didn't involve the interproximal area, but also sealants were completed. The child did very well, and mind you, this is 2018. We also have the next time she comes back is in March of 2019. So importance regarding what to do is recommendations on your diet, right? If we can make sure that we reduce the amount of sugary drinks, making sure we're brushing at least twice a day. The most important one is at nighttime. We see the treatments and we see something of an overlap here on tooth L. We also see something going on of an overlap on tooth S. And so far the treatment is holding up. So we decide to watch those interproximals. The next recall is September 2019. So guess what? Our restorations are still intact. We still have this. We have some teeth that are showing interproximals. So again, recommendations of fluoride, right? We can also prescribe Prevident. So these are all means that if one doesn't have the means to do any restorations or maybe another sedation, we can definitely recommend fluoride or brushing at least twice a day for sure, making sure that their diet is optimal and less sugary. And then I know we began starting to see patients again, and notice that these x-rays are from September 2020, almost a year went by. She was due for a recall in March, but due to the pandemic, no elective treatment recalls were really being seen. So if you look, we do have some lesions that have what? Progressed. We look at in between. S looks kind of, you know, like there's a start of, definitely tooth B. There is a lesion that's definitely going a little bit further into the dentin. So the treatment options for her were to do another sedation. Mom did not opt to do the sedation because at that time we had to do COVID testing prior to. So imagine trying to do the intranasal swabs on these children. So we learned a lot. Like I said, we learned that SDF can buy us time. Also, parents must be accepting of this. That's the negative part about it, is the black. So parents opted to do a nitrous instead of doing SDF, which this is a good case to do, opted to do nitrous and actually do the Hall crowns. Patient was really cooperative with nitrous, and I've never seen a patient try to wrap themselves up before, but we did have a papoose board ready to go. And there was no need for it, luckily. Okay, so I'm sure it's kind of odd to see a patient wrap themselves up, but she used it like a little blanket. These are the separators. So typically, if you can, try to place them in 5 days prior to. Also, we do a lot of plan A to plan H to plan Z, where we are planning to do crowns, but if we can't, can I do, for example, put some separators in, see what I can get, and actually do a modified Hall crown. We've done that before in an instant. Here is a picture of the separator. So we opted to do a crown on tooth B. So you have separators in between B and also tooth S like Sam. So we also had her bite. Take a look at what the bite looks like, because remember, Hall crowns, as Dr. Dida mentioned, they might feel a little bit higher or at least a little bit harder, or like something's not right. So looking at the bite, you can see that also this patient has a little bit more wear of these teeth, right? Again, we use gauze, no isolite was used. And we use gauze, no hand instruments or anything was used for this. And so here's our fit for the crown. Okay. It looks like blanching. So if you want to pay attention to that, look at the lingual side. So with crowns, sometimes they are very long. They need to make sure that they're not causing too much blanching. So this crown was trimmed. And then this was trimmed, but I want you to pay attention to the lingual side. There's no more blanching compared to what we had previously. So the fit was great. And so we got one done, we cemented, and it was all go. She was great and happy. And her occlusion, I'm sorry I didn't include a picture in here, but it was really good. So guess what? We took x-rays afterwards. It's really hard. We wanted to make sure how everything was. So nothing in between tooth K and L and tooth A. Well, we tried to convince mom regarding the SDF, but at that time she still refused to put the black. So she keeps coming back for her recalls. And this is from March of 2021. We see that tooth I has progressed. It's a little bit harder to tell. Tooth A looks like it's progressing, and also tooth S. This is a close-up of tooth I, and you can see that there's definitely interproximal, and that would warrant another crown. So we were proposing to do another crown. But then she doesn't come back till April of 2022. So it's getting a little bit worse. The crowns are intact. We again proposed treatment. I believe due to finances unable to complete, and comes back this year. So we're going from April 2022 to now June 2023. In this, you can depict, we have lost already one stainless steel crown, one of the Hall crowns that we placed. We have a permanent tooth now. Tooth L is still in place, but the permanent is arising. You can see, and I will try to zoom in. If you notice, tooth S is definitely worse, but it's about to exfoliate. So recommendations for diet, maybe fluoride treatments, those do help. Now let's take a little bit of a closer look. So we have our Hall crown that's about to come out. This looks good, nothing going on tooth J and the mesial. And tooth A, I know I have a permanent tooth. I believe we recommended you can do an SDF, or you could do, for example, a small class 2, but it looks like it's holding up, our fluoride applications. And this tooth is already beginning to exfoliate. So Hall crowns can work to prevent any, more caries going and extending. It's meant to seal all those, potentials of any bacteria getting in there or food to cause the caries to grow. Does anyone have any questions regarding, I'm gonna stop sharing and then we'll go to the second case, but does anyone have any questions about this case? And if you want to, I would have to share again. How would you like?
Anybody have any questions about the case before we move on to the second case?
Okay. Then, second, share screen. And are you seeing the screen?
We're seeing the presenter view.
Okay. Okie dokie. Getting there. Now you're able to see, is that
Yes,
correct?
now we're seeing that. Yes.
Perfect. I do apologize for those. So the second one, I want a little bit more participation. That's just, I will need you to unmute them. It's a 3-year-old, and this 3-year-old has several caries, cavities and holes is what mom says. And she did have a sedation because she did have abscesses on tooth B and tooth I. So you could see from these x-rays that they obtained, she does have more caries as well. So tooth I and B were extracted under sedation. Then we were able to get only these other pictures. She has a history of SDF application. You can see the SDF, how it stains. These are the front teeth. This parent was willing, as long as the patient wasn't going to get any abscess. She just wanted to stop the progression. It was also applied on posterior teeth. Now take a look at this particular, let me get my laser pointer and you can see, I'd like to ask the audience, this tooth is pretty large as far as the caries goes. It's very cavitated compared to this other tooth. And I'd like to ask the audience, if you would SDF, would you try to place an interim therapeutic restoration? Or would you try to place a Hall crown? And the history is no pain. Just that for right now. What would you like to do? What would you, I don't know if in the chat some people can we see a raise of hands who would like to try SDF? No hands are up.
Hello, can you hear me? This is Dr. Murphy.
Yes, Dr. Murphy.
I'm a fan of the ITR. And that would be my choice, just based on, at least within our practice, because of management issues. You said there was no pain, there's no other symptoms. So we're trying to do what we can to give them the best care that we can, with apparently the parents and ability to pay have got all of its issues about this, but I think they would accept the ITR, and I think it would be a service.
Yes.
That's my thought. I'm an ITR person.
I'm an SDF, I'm an ITR, I'm a Hall
SDF,
crown.
SDF, all of those letters.
All of those, SDF, ITR, and Halls.
SDF,
I
ITR.
wasn't such a
on
big
that side of
fan.
the chart.
I wasn't such a big fan, but I've seen how the Hall crowns can definitely help us out. Okay. And also it's more about the behavior. So can Hall crowns possibly be done on the adults? I think we do also have adults, or at least those participants, where you may have, say, permanent crowns as number 19, number 30. There are stainless steel crowns for those teeth. Some parents may not enjoy, but that is an option, at least to try to keep them in, until they are, especially when they're this big. When we're looking at this particular tooth, let's see if it doesn't, this one, like I said, you can scoop it out, hand instruments, or some people choose a slow speed. And this is a very, very young child. And the times that I've done this, and I try to keep up with our patients here, it's always important to review also, how's the eating, how's the diet, are we brushing? Because I've seen veterinaries last a pretty long time. I also have other cases in where it's a medically compromised patient, because most of the time these things are not just for patients who don't have the insurance, it's medically compromised. Let's just say there's someone who has such a complicated or complex medical history that if you do take them and are able to take them to the operating room, what occurs is they need to stay overnight for 23 hours. they need to have, they have a specific emergency plan for this particular patient. Well, this patient I started at age 2 and currently now age 6. And the condition is called glycogen storage disease. So they were just basically feeding every 3 hours. Okay, and still on the bottle. And we were able to do something, not SDF, mom was opposed to SDF, and that's fine. So I did strip crowns. There is a article by Dr. Wagner, who from University of Washington in Seattle, and they published strip crowns. They have pictures, wonderful. And there's, I believe they were with glass ionomer or resin modified glass ionomer, and they lasted pretty long. You know, we're looking at about 2 years on some of the cases that they presented. And for mine, they lasted until basically the teeth fell out. So we did those, and currently I did do Vitromere. So we did some just like that big of a hole, and I did some resin modified glass ionomer. And she has now gone, and there's one that has facial on tooth B, and we got a Hall crown on her now, and she is now 6. But it's more because of her medical condition. She's not a sedation candidate also. So we have different options, not just because there is no financial, or they may have a financial hardship. There's also due to medical reasons, or definitely in our case for pediatric patients or those with special healthcare needs. And we're talking also children or adults, right, with special healthcare needs, that you have options. Sometimes I like to start with glass ionomers and then, okay, this isn't working, maybe move to the SDF, but eventually you need something more permanent. And it's kind of, I want to say, and I tell my residents, baby steps. Let's start with this, because mom's not ready to see stainless steel crowns, because this patient is going to go to the OR eventually in 3 months, but we're just putting that glass ionomer, and it's white because mom doesn't want black. So baby steps, you're kind of progressing based on the needs. Also, the behavior is the most important thing, right? Because a lot of children, a lot of parents do not want their pets. Or also, we also use what we call a pillowcase in some of the special needs, or at least for the adults, where your hands go behind and you strap a little pillowcase, and that way they can't lift up their hands. Regarding this one, I don't know who would do a Hall crown, because you can put separators and also try to do a Hall crown in that case.
Thank you. Yes, in the chat we see a few Hall crowns and ITRs. Yep. Thank you for that. Does anybody have any questions for Dr. Contreras or Dr. Daida?
And then
So
for the
I have a
previous
quick question, Dr. Marwaha here for Dr. Contreras. So did you end up doing a Hall crown, or what did you end up doing for this patient?
For this one?
Yes.
It's on the books, and I don't know who will see it. I'm not sure. I just know that I just barely saw it. I think we're hoping to put them in the operating room, but
Okay.
This one, I wasn't the attending cover.
Okay.
Because we're encouraging a lot to take or photos, because at times you can't take x-rays, correct? So at least as an idea, something on paper. Oh, well. So I believe this child will do is we can sedate them or come on in and do interim therapeutics, as long as it's okay with.
Dr. Contreras, it might help to turn the video off. The connection seems a little bit. Okay, we might have. Lost. Oh, all right. It may, Dr. Contreras, can you hear us? Right. It may help to turn the video off. We were having a little bit of issues here.
There we go.
All right, perfect.
Thank you for your response, Dr. Contreras. Appreciate it.
You're
I have
welcome.
one more question.
Yes, Dr. Murphy.
Yeah, Dr. Contreras, what is the code number that you use for your ITRs, for your glass ionomers?
Okay, depending on what your insurance are, but these are. If it's a restoration and I remove caries, some people will be using, for example, a therapeutic restoration. I believe the code is 2940. I can't know, not 2940, 2340. That's the it's the sedative one.
Yeah, okay, so you use the one for sedative at 2940?
Yes, I believe that's the code. I was kind of confused.
Okay, thank you for that.
Yes, and of course, we know that SDF, the code is 1354 as well.
1354, okay.
Do we have any participants that see Medicaid? By any chance? Yes. And I know that there's been some changes regarding, I know DentaQuest, for example, did always pay for the SDF, and now I believe MCNA is already, as of September 1st, is beginning to pay for the SDF. But make sure you read your manuals because there's always a fine print.
Thank you. And I see a question from Dr. Shah. Would you be able to share a question with us?
Hello, doctors. So, quick question about the Hall technique. Are there any contraindications? And if not, why not just make them a standard of care, considering that we can probably avoid anesthesia and just giving the patients a better experience?
Oh, you want to tell them?
Well, I mean, the big contraindications would be if the tooth can't be restored due to space loss, or if it's pulpily involved, or if the patient is too young to cooperate in placing a Hall crown.
Of course, and one last extension to that question: is it possible in a patient some of the teeth are adversely affected, so you cannot do Hall crowns, but the other, let's say, other 3 molars, one of them was contraindicated for Hall, so you do 2 crowns, 2 molar crowns with Hall, and then one with a regular stainless steel with nitrous and perhaps anesthesia. Is it possible?
Great question. Due to behavior, we did have an incident where you know that you have a child that is moving and you're already numb. So options are to stop. This is not safe anymore. So what we did was, on this particular case, the resident went ahead and one was prepped. Basically, we created slices and occlusion was done, and did a modified Hall crown, meaning not everything was removed. Just you got the occlusals done, you still had a little bit more caries, you were beginning to do one of your slices, and then he lost it. And then so they did one more slice and just fit the crowns.
Okay, thank you.
Did that answer your question? So we've had to do that, but that's one of the cases. It's hopefully your patient is doing well. It's all behavior, it's behavior, and making sure that you also adapt the crown adequately, because you may have a crown that, okay, this is the one, then we take it out, and then you're gonna make sure you are contouring it. So you may crump it a little bit, especially on the mesial and the distal. You saw the x-rays from the presentation. That's something that we tend to forget, to make sure it's contoured towards the tooth, so that there are no possible entries or the cement dissolving, and then we have what? Recurring caries that can start due to lack of cement, correct? Because remember, it's the crown. There's no chamfer, there's no shoulders on these crowns. You're not prepping, you're just placing them. And again, this is from Scotland. It came from Scotland, the Hall crown technique. It's just that we always want to practice the standard of care. I don't believe that not being able to, this is again, there are other alternatives, right? It's when you get to the point where you saw that big molar, what are you going to do?
Okay, thank you. Thank you very
Okay,
much.
Thank you so much. I see that it's already one. So thank you for joining us for the Dent Echo. And special thank you to Dr. Contreras and also Dr. Daida for a great presentation, and for everybody for joining us today and also contributing to the discussion. Please complete the post-session survey. The link is in the chat. And if you have any cases that you would like to present, please email us at dentecho@utesca.edu. And we hope to see you in 2 months in November for our next Dent Echo. Thank you so much, everybody. Have a great afternoon.